Okay, so let's talk about immunodeficiency. So we've stopped with autoimmune disorders, and we'll briefly talk about immune deficiency. And you can be born with immunodeficiencies, right? Or you can have them due to some kind of an illness or a disease process that's occurring in your body or from drugs. So let's talk about primary immunodeficiency. And that's typically congenital, meaning you've had it since birth, and some of them are inherited from your parents. So there's an assortment of primary immunodeficiencies. I think the most important aspect to take away from this is that it's occurred since childhood or since birth, and your immune system is weakened. Okay, and why is it weakened? Well, it could be from a B cell deficiency, it could be from antibody deficiencies or defects, it could be from T cell deficiencies, or a combination of them. So notice all of these deficiencies in the immune system that you can inherit or be born with are really of the adaptive immune system. And whenever you have any kind of immunodeficiency, there's always an increased risk of infections. So always think of patients that are coming in with fevers, chills, anything like that, and they're immunodeficient. That's very important to recognize, okay? And also, if you have immunodeficiencies or you're immunosuppressed for a long time, you're at risk for developing cancers because the immune system is really involved in monitoring the body for the formation of cancer cells and destroying them even before they form. Okay, so primary immunodeficiency since birth. Secondary immunodeficiency is something that's been acquired later on in life, right? So whether you're an older child or you're an adult, it's something that's occurred to your body, and so we're calling it secondary. So definitely secondary immunodeficiencies are more common than primary immunodeficiencies. There aren't many people that are born with an immunodeficiency at birth. It's relatively uncommon. Secondary immunodeficiencies are typically from diseases of the body, such as bone marrow suppression, or say you have a cancer in your bone marrow that's destroying your bone marrow and you can't make proper white blood cells anymore. Another example would be AIDS, where the HIV virus gets into the CD4 T helper cells, which play a very large role in your adaptive immune system, and it gradually destroys the CD4 cells, and they decline in number until you finally get the disease state called AIDS. Okay? Chemotherapy is a very big cause of a secondary immune deficiencies. Cancer is very common in the population, and many patients are receiving chemotherapy agents that try to treat the cancerous cells, but at the same time is harming and suppressing the bone marrow, plus other rapidly dividing cells in the body, such as your skin, your gastrointestinal tract, your hair, the mucous membrane, such as in your mouth. They're all rapidly dividing areas that are harmed by chemotherapy agents. Okay, bone marrow failure, basically bone marrow suppression, or any bone marrow disease, such as a cancer of your bone marrow, or just bone marrow failure where the cells have stopped being produced. Okay, so let's talk about a bit about HIV. So HIV is acquired, right? So it's going to be a secondary immunodeficiency. And HIV is what we call a retrovirus, and it attacks the CD4 cells in your immune system. And we call it a retrovirus because it's actually an RNA virus, and it has to convert to DNA in the patient's CD4 cells in order for the DNA to now get into the patient's genome, the DNA of the patient. Okay, so that's why it's called a retrovirus. It has to go from being RNA and then copy itself to becoming DNA. So the virus, like all other viruses, get into the cell, and the virus uses the host cell machinery to make new viral particles. So that's pretty ingenious. So a virus by itself really can't exist. It can't replicate until it gets into one of your cells, where it takes over the control of the nucleus and all the machinery that's used to make protein to produce its new viral particles. Okay? Bacteria don't do that. So let's look at this image here. You can see an HIV virus attaching to a CD4 cell. It's going to enter with its RNA into the cytoplasm. The RNA is going to need to be converted to DNA. That's why it's a retrovirus. The DNA is going to insert itself into the host cell genome. Okay, and then finally, once it's inserted itself into the genome of in the nucleus of the CD4 cell, it can now make its own mRNA and its own proteins, which are going to allow it to make new viral particles that will then get released and infect other CD4 cells. Okay, so it's a whole cycle of the virus entering the CD4 cell, using the CD4 cell machinery, making thousands of new viral particles that then break out of the CD4 cell to then go and invade other CD4 cells. And in the process, that CD4 cell is now destroyed. Okay, so let's look at the course of an HIV infection. So say that a patient has just acquired HIV. Let's use, for example, through sharing of needles with IV drugs. Or it can be through unprotected sex with someone who's HIV positive. The acute HIV infection, which we'll call the primary infectious phase, are really symptoms of a cold, right? So a patient feels systemically unwell. They've got aches and chills and sore muscles, and really like a flu-like illness. And very hard to tell the difference from just a common flu or cold. Okay? And then they can seroconvert, meaning the body makes antibodies to try and attack the HIV virus that's now infecting the CD4 cells. Okay? And that can take 1 to 3 months to occur, right? So when we're testing patients to see if they're HIV positive, the seroconversion and the antibody tests that we use can be negative for the first 3 months. And that's why we do repeated tests. We don't just do one test, say, at a month. We repeat the tests. Okay, now this is followed really by no symptoms, right? So you've had this primary infection and that cleared, but the HIV virus is actively in your CD4 cells, and actively destroying them. You just don't have any symptoms, okay? Because your CD4 count before the HIV entered the system was very strong, right? And so it has to reach a certain level as it declines, as they get destroyed, to then develop symptoms of AIDS, right? So that's called the latent period, where you have the HIV virus in your bloodstream causing infection, but really you have next to no symptoms, okay? But during that period, the virus is actively replicating in your CD4 cells, and if the patient knew that they were HIV positive, really what's happening is the CD4 cell count is declining. And this can last for years before symptoms begin, right? So it can take up to 10 years until the T helper cells are so destroyed that now they have a significant immunodeficiency and they're going to develop illnesses from such a weak immune system, okay? And that's where AIDS comes in, acquired immune deficiency syndrome. So if you're HIV positive, you don't have AIDS until one of these occur. So the first one is your CD4 cell count has dropped below 200, okay? Or you develop what we call an AIDS-defining illness, which is usually some kind of an infection or some kind of cancer that's extremely uncommon in the general population because our immune system would be so protective and able to defend against those particular infections, okay? So it's either a CD4 cell count of less than 200 or what we call an AIDS-defining illness, and we'll talk about some of them. And then you have AIDS, okay? So for example, if you had a CD4 cell count of 300, but you developed one of these very uncommon diseases and infections, you have AIDS, okay? Or if you haven't developed an infection yet, but you have a CD4 cell count of less than 200, you have AIDS, okay? Okay, so let's just look at the sequence again. There's the initial infection with the virus, the HIV virus. That's the flu-like symptoms that occurs typically days to weeks after getting HIV. Most patients will just pass that off as a typical cold or a flu. And then you go into that latent phase where you have chronic HIV infection with really no symptoms. That can go on for many years. You might discover 10 years later that you now have some kind of strange infection that takes you to a healthcare professional and you end up getting diagnosed with AIDS, okay? Some patients come in earlier and request an HIV test because they've been involved in high risk activity and they'd like an HIV test, okay? So they may be completely asymptomatic and they're HIV positive. AIDS patients, as we mentioned before, is that CD4 cell count, which is your T helper cells. They've been really destroyed with counts 200 or lower. And this is where patients develop opportunistic infections, meaning infections of the body that a normal, healthy person would never get, okay? So that's why they're called opportunistic, because the infections are taking the opportunity to get into the body and cause infection where under normal circumstances with a healthy immune system it would never happen, okay? So that's opportunistic infections. And other AIDS-defining conditions and diseases that we'll come to. Okay, so let's talk about transmission of HIV. So how do patients acquire HIV? And it's typically coming into direct contact with certain body fluids from a patient that is HIV positive and has detectable HIV virus in their bloodstream. And we'll go into more detail about that last fact on another slide. Okay, so what are these fluids? Well, the fluids are typically blood, semen, rectal fluids, vaginal fluids, and potentially breast milk. Okay, so when we look at the list here, well, sexual contact can definitely have blood-to-blood contact. There's definitely semen involved potentially, so that's another source. Breast milk, it's possible to transmit HIV through breast milk. Vaginal secretions, definitely, and there can be blood in vaginal secretions. The blood-to-blood contact, so contaminated needles and sharing of needles is a common way to acquire HIV, right? So the needle's gone into an HIV infected person, and now someone else is sharing that needle with them. They introduce some of the HIV infected blood into their system. In hospitals, we have what's called universal precautions. So everybody is assumed to be HIV positive. Now, we know that's not the case, but we treat all body fluids, including blood, of course, to be HIV positive, and we're very careful in terms of disposing of needles, disposing of anything that could have body fluids or blood that could then come in contact with a healthcare worker. Okay, blood transfusions are a potential way of getting HIV, but because of the screening now, it's far less common. Okay, so blood is heavily screened for certain diseases such as Hep B, Hep C, and of course HIV. So if you're in contact with someone who's HIV positive, you're not going to acquire the HIV virus unless there's been some kind of sharing of blood or certain secretions from the HIV positive patient. Okay, and remember, a patient that's infectious, even though they have no signs or symptoms, which we call the latent period, they can still transmit HIV, right? So there's that long period between acquiring the primary HIV infection and then the signs or symptoms that can occur many years later. They're still infectious to other people. Okay, so let's just go through a few common scenarios that you can acquire HIV. So having vaginal or anal intercourse is a way of getting HIV if the patient is HIV positive. Okay, sharing of needles or a needle stick injury. Okay, so people that are sharing IV drugs with the same needle for sure can acquire HIV if one of them is HIV positive, or a healthcare worker that gets a deep wound from a needle stick injury, they can acquire HIV. Very low risk with superficial needle sticks, higher risk, still low, with deeper needle sticks. Okay, so that can happen in the emergency room. It could happen during surgery, where somebody touches a sharp object and comes in contact with the patient's blood, and they happen to be HIV positive. Transmitting from mother to child during pregnancy can occur. The mother can also transmit HIV during birth and during breastfeeding. Okay, but this is far less common now because of using HIV medications during pregnancy. The chance of passing on HIV to the fetus or even during delivery is significantly lower because of those drugs. Now, we do counsel patients that are receiving blood that there is a minuscule risk of acquiring some kind of a blood-related infection. And we do mention HIV, but it is extremely small to get HIV from a blood transfusion, any kind of a blood product, or an organ transplantation, because it's so heavily screened. Okay. Okay, and what about skin-to-skin contact? Well, you're not going to get HIV from skin-to-skin contact unless there's open bleeding sores on the patient and also on the non-HIV person, right? So it's that blood-to-blood contact. Kissing, very unlikely, because you need those open sores or bleeding gums to have that sharing of blood. Okay, so really HIV is not spread through saliva. Okay, so let's look at some AIDS-associated illnesses. So these would be infections or certain cancers that would define the onset of AIDS in an HIV positive patient. Okay, so the first one we'll talk about is infections, and there's many more than these. These are just some examples. So opportunistic infections involve many different types of infections that can enter the HIV positive patient's system because the immune system isn't there to protect them as much. Okay, so in terms of respiratory system, tuberculosis, or another type of pneumonia called pneumocystis. Okay, in fact, pneumocystis was one of the first infections in the late 80s and early 90s that started to appear in males, right? And initially, we had no idea what was going on. Why were these males getting this very rare type of pneumonia? And it was only until it was discovered that their immune system had been ravaged by this unknown virus that ended up being HIV, leading to destruction of their CD4 cells, that we started to understand these opportunistic infections. Okay, so in the gastrointestinal tract, you can get an infection called cryptosporidium, which is very uncommon in a healthy person. Oral thrush, so candidiasis at the back of your throat, very uncommon in healthy adults. Sure, children can get it, or adults can get it after having been on an antibiotic or taking a cortisone inhaler for their asthma, but in general, adults should not be getting recurrent bouts of oral thrush. And this was also happening in the late 80s and early 90s. Males presenting with oral thrush. Okay, what about the central nervous system? Well, these are fungal infections that we're looking at here. Toxoplasmosis and cryptococcal infections. Okay, so toxoplasmosis is actually a parasite, and cryptococcal infections of the brain is a type of fungal infection. So very uncommon infections to develop in your brain unless you have a significant immune deficiency. So these we would call AIDS-defining infections. Okay. What about some malignancies that patients with HIV can develop? And they would be AIDS-defining infections, right? So there's one called Kaposi's sarcoma, and that's a cancer of the tissue of your skin, and there are these dark purplish type of cancers that occur under the skin that are called sarcomas, and they start to develop and appear all over the body. And also a type of lymphoma of the lymphatic system, so a cancer of the lymphatic system called non-Hodgkin's lymphoma, another AIDS-defining cancer in an HIV positive patient. Okay, so the treatment that we use for HIV patients or AIDS patients are what are called antiretroviral therapy. And antiretroviral therapy, just like any antiviral therapy, tries to stop the HIV from replicating in the host cells, right? Because HIV has to get into your CD4 cells, take over the CD4 cells, replicate, and then release new viral particles. So all the treatments are aimed at stopping some part of that process, okay? And typically patients that are HIV positive or actually have AIDS need 3 or 4 different drugs that they stay on for the rest of their life to stop HIV from producing new HIV particles, okay? And it's really important that they stay on these 3 or 4 drugs and they don't miss their doses. If they start to miss doses of their HIV antiretroviral therapy, the virus starts to be able to wake up again, start to replicate, and that's where you can develop new strains of HIV that then will become resistant to the medications. Okay, so one of the main pieces of advice that patients receive when they're taking HIV medications is that they don't miss doses. They need to be very adherent to their medication schedule. Okay, so let's look at some opportunistic infections. And because there's so much experience with HIV now and AIDS, we've come to understand that opportunistic infections, different ones arrive depending on the CD4 count, right? So if you have a CD4 count above 500 and you're HIV positive, that's enough that you're not going to get opportunistic infections. You're going to get what other people get, right? Just a community-acquired organisms, just the run-of-the-mill infections that we can all get. And then you'll see that as the CD4 count starts to drop, very predictable infections start to attack the body, okay? Not that you need to memorize this at all. It's just to show you how these different bacteria and viruses and funguses start to come into the body as the immune system gets weaker and weaker and weaker, okay? And you'll even see that there's some cancers in here too. If you look at the bottom, there's lymphoma developing. So if a patient goes to an HIV clinic and say they have AIDS, based on the CD4 count, the healthcare provider will predictably know which infections they're at risk for based on that CD4 count. Okay. The other thing I want you to remember is whether you're HIV positive and you don't have any symptoms, or you have full-blown AIDS with opportunistic infections or a CD4 count below 200, you are still taking antiretroviral therapy. Okay? So even if you're feeling 100% well, but you're HIV positive, you're taking 3 or 4 medications to completely inhibit HIV division and replication in your T helper cells, and to try and stay healthy. Okay?